Um, Great. So, welcome again to the Dharura Global Emergency Care Grand Rounds. This is our February edition, and my name is Chris Boyle. I'm a ED registrar. I'm working in Bristol, and I've been involved with Dharura for the last 18 months, and I'll be hosting tonight. Um, just a bit of background for those who haven't joined us for the Grand Round before. So Dharura itself tries to support ethical, sustainable, equal, and reciprocal global emergency care health partnerships. And Dharura strives to allow the health systems and their teams to gain mutual development through sharing knowledge, skills, and innovations. So the aim of this Dharura Global Emergency Care Grand Round is to provide another platform for us to do that. So we have lots of different speakers join us on a monthly basis, and they share topics within primarily emergency care, but it can be other areas of interest or specialties as well. We try to look at case reviews, research, audit, QI, or the roles of those people who are working within this area of emergency medicine. So today we have two speakers. I'll give some fuller introductions later on after going through some house rules, but we've got Rose Sikote from Nanyuki in Kenya and Sara Daglio from the BRI. So thank you very much for both of you to join us. I can see Anna just join us. Hello, Anna, as well. Thank you very much for joining us and offering to speak. Before we do go on, a few house rules. If everyone keeps their mics off, unless you want to raise your hand and ask a question. If you can and you're able to, I appreciate it's not always you're able to, you could put your cameras on so we can see you. It just leads us to have a bit more of an interactive session. We really like to hear what your thoughts are and hear from you. If you don't have the facility or capability to do that, but you want to ask a question, pop anything in the chat and we will come to your questions at the end of the talk or at the end of the session. So please do that. If you haven't done already, I've just posted in the group. You just pop your name, your location, role, and your email address onto the chat. Then we can add you to our WhatsApp, add you to our mail list, and give you some feedback. Give us some feedback later on, and the register will be part of that as well. As I mentioned, we are recording a session. There is a YouTube channel. I will share the link for that YouTube channel. There's a number of previous sessions on there. Feel free to have a look. That's about it, unless there's anyone else who has any burning questions before we start. Great. So if you get cameras on, if you're able to, and please, any questions throughout, let us know. So we're really, really glad and privileged to have two great speakers tonight, and Rose is going to kick us off. So Rose Sikote is co-lead of simulation team Nanyuki Teaching and Referral Hospital. A lot of people on this call probably know Rose already because she's been heavily involved in Dharura. She's going to talk to us today about the simulation team at Nanyuki Teaching and Referral Hospital. I've had the privilege of spending some time with them, and they're doing a fantastic job and fantastic work, both within Nanyuki Teaching Hospital and to sort of wider EDs and areas around Kenya. So, Rose, I'm going to hand over to you. You've 20 minutes or so. Please take the time and we'll have some questions for you at the end, no doubt. So thank you very much again.
Thank you, Chris, for that introduction. Good evening, everyone. I'm Rose Sikote, ER nurse, Nanyuki Teaching Referral Hospital, and I'm also a co-lead simulation facilitator, a position that I've had for the couple of around 11 months now. So I'll start my presentation with a couple of hypothetical questions. And I'd like you to picture your work environment, the department where you work. Who's there? What cadres are represented? How often do you and your colleagues go for a professional development courses? And if you do, how are they delivered? Now think about the diversity in the medical field. Researchers work around the clock, inventing things that would help improve the quality of care we offer our patients. In that regard, new treatment protocols, guidelines are released every now and then. How are these brought to the attention of our colleagues and the students attached in our hospitals? How do we ensure that we have a unified approach in the management of our sick patients? Is it through CMEs? Are we able to do on-job trainings? In May 2023, we got an opportunity to be trained as simulation facilitators. This was done by Dr. Claire with the support of Bristol Fellows. 20 people picked from different cadres underwent this training for 2 weeks. The numbers have since increased. It was a very new concept being introduced in our setup, and we were very eager to see how everything would go. The trainees got an opportunity to conduct sessions within the hospital, especially in the emergency department and the critical care unit. Through simulations, the new protocols and guidelines and clinical skills are shared in a safe space. Being a teaching hospital gave us an excellent platform. Staff and the students attached to the hospital benefited greatly. With the growing demand, this was a factor that we couldn't overlook. Facilitators had to create time during their day offs to run simulation, and this proved to be difficult and inconsistent. It was largely sorted in Feb 2024, just about a year ago, when myself and Titus were picked to lead the team. And this meant that we are able to work 2 weeks on clinical and 2 weeks on the trainings or simulations. It's worth mentioning that NTRH also serves as a referral center for a couple of dispensaries and sub-county hospitals in Laikipia East and Laikipia North. There was dire need to trickle down the knowledge and the skills to the staff in these facilities, just to ensure that before a patient is referred to us, they get the bare minimum. Appropriate care is given before they are transferred. And this means that the primary care they receive was in accordance to the current clinical guidelines. Now, to achieve this, trainings were introduced to the staff in these clinics and were able to participate. To mention the clinics that we were able to reach, these were Dol Sub-County Hospital, the Lewa Conservancy Clinic, and Borana Conservancy Clinic. And on each clinic visit, staff working within the proximity were always invited. And on each day, we were able to attract at least 12 attendees from different facilities. Now, what were our responsibility as lead facilitators? One was to engage the stakeholders in the hospital. That's the management, the ward in charges, and the students lead. It's very important to engage the management because we couldn't work in isolation. They needed to know what is happening when and where, and to offer support accordingly. The ward in charges needed to be aware so that they can release their staff and students to attend these sessions. And engaging the student leads meant that we were able to understand their learning objectives for the team that were there and to see how best we could support them achieve their goals. We did a need assessment for different cadres within the hospital and created a simulation schedule. A survey was conducted, and this informed the choice of topics. It was important to tailor-make the sessions to suit the needs of each groups well. We adopted the Simpson framework, which guides us. For instance, we could do a simple clinical skill teaching all the way to running a complex scenario with various complications. And we had to be keen on who we subject to what type of scenarios. Another responsibility that we had was to coordinate the team of facilitators by delegating roles and giving responsibilities. As a leader, we had to understand the team dynamics and identify the strengths of each member and to empower them to keep improving in the skills. We have a very strong team that are able to conduct sessions in the absence of the lead, and this great improvements. It's worth mentioning that the same team also conducts sessions in the rural clinics with the support of the BRI fellows. Planning and mobilization of planners is also part of our responsibility as leads. We had to plan ahead of time. One of our members was keen with sending out posters ahead of time to notify people what we are doing when. We run simulations twice a week in our hospital and once a month in the rural clinic, but it's basically scheduled. And sometimes we have planned in situ simulations in different departments, like the emergency in the triage department, as well as the critical care unit. At the end of the month, we have to write reports and give feedback. These are sent to the relevant persons. We communicate the challenges that we've identified or faced throughout the month and brainstorm on ways of mitigating them. As part of the ED team, I would want to say that we are seeing quite an improvement in the quality of referrals that you are getting from our rural facilities. That is after conducting simulations and sharing the protocols and guidelines. There's a lot of improvement between the staff in the ED, in the OPD, and the rural clinics. In simulations, we also look at communication skills, because without adequate communication, then everything else just take a waste. So we are seeing a lot of improvement in that end. We would receive calls from the rural clinics and they're asking maybe for guidance. And this is a very good thing that we are experiencing right now. Our staff in the OPD and the emergency department are greatly empowered with the appropriate knowledge and skills, and they demonstrate a lot of confidence at which they approach the various cases that we get, whether medical or trauma patients. So when we call in, like we have like a mass casualty incident, they know what to do when they get there, and it's a really great improvement. Our team managed to record some videos. These range from videos on A to E assessment, different management of trauma cases, basic life support, the use of a defibrillator, just to mention a few. And some of them are already uploaded on the YouTube channel. These videos come in handy as part of training aids. Before sessions start, we show this to our learners, and they really appreciate, because we understand that people who understand better when they see than just being told what to do. Yeah, so we're still working on this and getting more videos coming out soon. A lot is in play when it comes to patient outcomes. It's difficult to say that whatever outcome we get is directly related to simulations that took place. The impact of simulations is immeasurable. A recent survey was done at NTRH, and it was to check on the confidence and the competence levels of staff before and after the sessions. And we got really interesting results. At the end of our sessions, we always allow our learners to fill out feedback forms, and we get positive remarks that learning through simulation has greatly improved the way they approach different clinical cases in their departments. They also tell us on how we can improve or what else they would want us to capture in the next sessions. So it's a very good way of communicating with our learners. At the end of 2024, we were able to conduct 20 simulation sessions, cutting across different sim rooms.
Enjoyed that I would have had no one actually shared their opinion. I really haven't gotten to the point where I can make fun of someone who
I'm sorry, I got there's someone who needs to post them. Okay, thank you, Rispa. Yeah, so we've done like 70 simulation sessions cutting across different sim zones. So that's different case scenarios altogether. And cumulatively, we've had about 370 clinical staff attending simulations. This means that by cumulative, I mean that one staff can come for up to 5 sessions. And it's a very good number when you look at it, because it tells us that people are appreciating simulations and they're able to come back more and more. I mentioned earlier that we attract a lot of students who come in for attachments. And in the year 2024, we were able to get 279 students passing through our simulation lab. Our team have been empowered through attending a series of different trainings, both internally and externally. Just to mention a few, we've done triage and the emergency care course, that is TEC, delivered by the Emergency Medicine Kenya Foundation. They've done the Dharura emergency care course. We've recently done BLS and ACLS at the Kijabe Hospital. And myself and Titus, we underwent a clinical simulation educators program at Aga Khan University. So it just didn't end with the training we received from Claire. We are still getting more trainings, and we are feeling even more comfortable to handle different case scenarios. Having learners coming in for simulation is one thing, but having them come again and again is another. For all our sessions, we are keen to take care of the psychological safety of our learners. Just think of the traditional classroom teaching that we received, where you feel threatened so in our simulations, we have rules, also known as the simulation contract, that is well elaborated to learners before each session. We also have a debriefing tool that guides us during the debriefing session. Debriefing and the briefing is the most important bits in simulations. Questions are asked and feedback is given during this session. And what really matters is how we frame our questions and how we make the learners feel when feedback is given. How do we tell a learner that that approach is outdated, or they are making a mistake? If the learner felt threatened, judged, or disrespected in any way, they will never show up for another session. So that's where the psychological safety comes in. Simulations is not an assessment. In simulations, we don't kill our patients, not unless you're running a cardiac arrest scenario, which is beforehand communicated to the learners, so they're well briefed before they get into the scenario. In simulations, we don't frustrate the learners. We guide them through our case scenario in a safe space where the learners are allowed to make mistakes and learn from them. I acknowledge the entire team in NTRH for their endless commitment, hard work, and great teamwork. The NTRH management for their support, the Bristol Infirmary for their endless support and guidance, and not forgetting our mentor, Dr. Claire, for always being there and guiding us accordingly. Thank you so much.
Thank you, Rose, for our clapping to you.
We're clapping here too. Thank you very much, Rose. It's always lovely to hear you speak. You have such a way of getting across your points effortlessly, and so thank you very much for speaking tonight. I'm going to open the floor to asking any questions about anything that Rose has talked about with her journey with becoming a simulation facilitator. And it's been quite a journey from what she's described here as well. So yeah, please, if you've got any questions, pop them in the chat, or if you want to unmute, put your hand up, then please go ahead and ask away. Go ahead, Anna. I can see a hand.
Hello. Hi, Rose. Thank you. That was such a good explanation, as Chris said, of all the really hard work that's gone on. Obviously, we're seeing like the ongoing project, but a long way into it. When you first started in Nanyuki doing sim, you were probably involved as a participant. How many people sort of came to the initial sessions? Because now, you know, like over 300 in a year is amazing, but I just wonder how many people are generally at each session, because I think that makes people feel safer when they're slightly smaller sessions sometimes.
Thank you, Anna, for that question. Yeah, at any given session, we get at most 12, depending on which sim framework we are using, and it can go to up to 20. So if you have 20 and that is maybe a simulation on clinical skills, we divide the group into smaller numbers so that they get the most out of it. And also, if you get 20 for, like, say, a scenario like a sim zone 1, and we have enough facilitators, we divide the group into 2 so that we are debriefed in 2 different groups, so that they are more comfortable to talk about what went well or what could be improved. Yeah. So we don't really advocate to having very huge groups, because most of them will shy and someone can go home with questions that are not answered.
Yeah, thank you. I think that's really important, but quite work heavy, resource heavy on you. And then the other question I had was, in the start, how did people get persuaded to come to the simulation sessions? You said you had the management on board. So were people assigned sessions to come to, or was it all voluntary, the participants?
Up to now, it's mostly on voluntary basis. We don't coerce our learners to come in for simulations. And like I mentioned, think of the traditional way of teaching, where people would fear to come in and maybe I didn't get it right and maybe I would be rebuked. So we still have people who are still shy to come in for simulation. So it's majorly our work as facilitators to try and make them comfortable and spread the word. So if you make this group comfortable, they'll go ahead and say, okay, went for simulation and it's not bad, go ahead and try it out. Yeah.
Great. So yeah, word of mouth, and then they keep coming back. So you're obviously doing lots
Yeah.
right. Brilliant.
Yeah.
Thank you. Has anyone else got anything?
Thanks, Anna. Anyone else on the call want to unmute and ask a question?
I was just going to ask, from my experience the last couple of weeks, we've been getting lots of students. Is there a plan, or how will you go about engaging the registered professionals who used to come? You said who came to like 4 or 5 sessions previously. They may feel like they've completed sim. Is there a plan on bringing them back now that it's been a couple of years in the process?
Yeah, to be very honest, bringing on board the qualified staff is not a walk in the park. It's one of the hardest tasks that we have. And we get that sway of this time they come in and the next time they don't come in. So we keep talking to them and persuading them to come. So there's no like a way that we can actually make them come. I don't say it's a gamble, for lack of a better word. But yes, we are still working towards that to get as many coming in.
Thank you.
I'll keep open up the floor. Anyone else has any other questions they want to ask? Suppose I'll ask my questions then, if that's the case. So I have a few, but I'll stick to one. I've known you, Rose, for over a year now, and I can see how much this role has benefited you. But I just wanted you to sort of add to maybe what you've already spoke about already, how this sort of role has changed you personally or professionally, and kind of share some of those experiences with the rest of people on the call.
Thank you, Chris. Well, I think this is just like an old story that I keep telling over and over. I came to the ED in 2021 from the female ward, and that was long before simulations were introduced in the entire hospital. And I would say that I'm one of the beneficiaries of learning through simulations. So what I know now, 90% of it is what was taught to me through simulation by the BRI team. And I have passion when it comes to teaching, and I could see the approach that they use, and I felt very safe to keep coming in for those simulations. They used to happen every Thursday between 1 to 2 p.m. Now, what has that done to me? It has helped me to improve my way of approaching things, my way of communicating with colleagues, my way of mentoring the students that we get, because I understand that people have different capability and different strengths, and there's the way you can talk to a student or a colleague who is making a mistake and make them hate that thing or hate you forever. So through the communication skills that are taught to me in SIM, I'm able to know how best to approach, and also in the ED, we are working as a team. How do you communicate with each other? Are we talking with each other? Are we talking to each other? So, and also when it comes to the skills, I'm more confident. I'm more confident when I have to support that C-spine in a trauma patient, because I've gone through this in simulation. I've done it on a dummy. So I have this patient, I know exactly what to do. And so I would say overall, I've really improved. And I owe it all to simulations. Yeah. Yeah. So I would say that again, before I did I got a chance to join in simulations. I went through a BLS ACLS course in 2022, and I was telling my colleagues the other day that the instructors can fail you. The instructors can make you feel like you know nothing. It's basically the approach. And that's why I say simulation is not an assessment. They help you walk through that scenario in a very safe space and you feel appreciated. Yeah. I hope that answers your question, Chris.
No, that's great, and thank you very much for sharing those comments and your experience. Rose. It's brilliant. I think from the advent of time, if there's any other questions, pop them in the chat, and we can come to them at the end if we have a chance. If not, we'll try and answer them in due course. And we're going to move on to our second speaker tonight, if that's okay. Sara, you happy for yourself to share the slides, or do you want me to share them?
No, I'll try to share them myself. Just a second. Thank you, Chris.
No problem. So this is Sara Daglio. She's a registered nurse, and she's the practice education facilitator in the BRI. It's a role that maybe most of us, or many of us, don't really know or haven't come across before. And with that in mind, Sara's going to give us a little bit of an explanation as to what she does and why she does it, and her sort of personal and professional experiences with that as well. So thank you very much again for spending the time on the presentation and speaking to us tonight. Over to you.
Well, thank you, Chris, for inviting me at this event. It's a pleasure for me to be here. I was just wondering if you could see well the slides. Yeah, perfect. Hello everyone, my name is Sara Daglio. I'm a nurse by training. I trained in Italy, and then I moved to the UK in 2018. And since I've been working in the Bristol Royal Infirmary, I'm now an emergency department charge nurse, and I work as a practice education facilitator. So I don't have a very different role from the one that Rose is having at the moment in Nanyuki, and that's why we thought it was nice to have the opportunity to invite Rose as well as myself in this chat, because I think we have a lot of similarities in our works, and because I know Rose, and you can see her in these lovely pictures from 2021, I know for sure we share the same passion for our job, but also teaching and learning ourselves. And also I have the pleasure of being the lead nurse for this charity, and who is hosting this event tonight. Today, I would like to talk to you and introduce to you, as Chris was saying, to a role that maybe not many of you would be familiar with, or who knows, maybe you have been working in a hospital in the UK or in Australia or in the USA, where this role is more common. But I would like to talk to you more about my role as practice education facilitator. I will discuss how PAFs, practice education facilitators, bridge formal and informal learning to enhance professional development. And I will conclude with the discussion over the importance of creating participatory learning opportunities in the workplace. To start with, I would like to show you this slide where the Royal College of Nursing has explained what's the career development pathway for an emergency nurse in the UK. To the left, you can see how a newly qualified nurse or a new nurse to the emergency department has the opportunity of becoming an emergency nurse by learning a number of skills and competencies. And from that stage, they can develop towards three different pathways. One is not excluding the other, but you could advance through clinical practice, or you could follow the educational pathway, such as what I'm doing myself, or the managerial pathway. And I think, however, it's a common role in the UK, I think it's still not very widely recognized there. For example, I was saying I trained as a nurse in Italy, and I don't remember encountering a role like this during my placements. That said, things are definitely evolving, and I truly hope that today's presentation helps you understand the significant value that having a practice education facilitator can bring to your workplace. And I think Rose's presentation was really giving you a very good glimpse of that as well. I would like to bring you back to that moment when you first started working in healthcare. For the most of us, I think we knew all that we were going to be using our communication skills as well as our clinical knowledge and hopefully some values that, of course, were expected by our professional bodies. But here's the thing, or at least this has happened to me, at least I was a bit of a revelation to realize that there were so many more skills I needed in order to progress in my career and succeed in my development. And these skills that had very little to do with what I've learned in university or on clinical placement, these were skills that, while not always taught to me directly, became essential in navigating the complex world of healthcare. For example, I had to be extremely good timekeeper for myself and my team, work in a team, sometimes very large, like the one I'm working with at the moment, which is consisting of more than 180 nurses. Be a leader, be a motivator for my team, teach sometimes, be of psychological support for my colleagues sometimes, as it's a very difficult environment where to work in DD, as well as developing my own resilience to come back to work and do the job every day. I had to have some IT skills, and Chris knows this very well because today is going to record this presentation to be able to share knowledge by uploading the presentation on YouTube. And, every day we learn something new with our IT skills. And I also had to learn how to collect data and draw conclusions for example, quality improvement projects, learn new advanced skills, participate to the production of a checklist and SOPs. And the list goes on and on and on. And I just wanted to put a spanner there, because if you are like me, a nurse, you probably have developed some strong technical skills to troubleshoot all those devices that we're working with at work. And this was just like a slide to say that I will agree with a billet, and I think you will agree with me as well, saying that workplaces are definitely not just places where you go and work. They are also places where you can learn and grow. And as Raud puts it, professional, managerial, and technical performance are normally complex and typically involve the simultaneous use of several different types of knowledge and skills. And this really resonates with me because it highlights how in our careers, we don't just apply technical knowledge, but we also bring together a variety of skills, interpersonal, strategic, ethical, and more, all at once. And what is interesting is that we don't always learn these skills in the same way we learn, like, for example, clinical knowledge. And this brings us to an important distinction, the difference between formal and informal learning. I would like to talk about informal learning and formal learning because I feel like my role as practice educator, education facilitator, sits somewhere between these two types of learning. The term of informal learning in adult education is often contrasted with formal learning. I described it here as unintended, opportunistic, and characterized by the fact that there is no teacher. And what makes informal learning quite unique is that it's largely invisible, either because it's not taken for granted, because it's taken for granted, or because it's not always recognized as learning at all. It takes place in informal settings like work and way beyond the traditional classrooms, and is essentially a blend of learning from others as well as from personal experiences. Now, as practice educator, I feel like my role is somewhere in the middle. This might sound innovative, especially when you consider that many healthcare organizations around the globe don't yet have a designated path in their teams. But historically, for a very long time, for the
whole length of human history, people have learned their jobs throughout apprenticeships, and it still happens in a variety of workplaces, and definitely happens in healthcare. And this is why some scholars, like for example Billett, challenge the idea that informal learning is unintended and happens by chance, unintentionally. He argues that, and I would agree with that, that just as schools have rules and norms to guide students, workplaces also have goals and practices that shape the tasks that employees undertake, and therefore how they are evaluated and learn from them. I agree with Billett when he says that workers aren't passive learners. These guys are definitely not passive learners. They have agencies, and they can make choices that can influence their learning. And most importantly, our workplaces, our employers, let's say, have a huge responsibility, because they can make choices that can support and enhance the workforce learning. And this is how I view my role as practice educator, guiding learning, supporting employees in making informed decisions that then will shape their professional development. But at this point, you may ask yourself, okay, but what is it exactly that we learn at work? Well, I kind of mentioned this at the beginning, like you learn so many different things that are not necessarily what you were expecting initially from your work. And this is why many refers to this number of skills as the hidden curriculum. What we learn at work sometimes is hidden, as I was saying, and is referring to all those lessons that we learn without them being explicitly intended or formalized. And in other words, they are all the lessons that we pick up along the way, often without really realizing that we're learning them. For a route, this idea is central to lifelong learning, and I find it very interesting. So he's arguing that at any stage of our careers, we are following two different trajectories. One is explicit, intentional, structured. We are learning purposefully what we want, basically. And then there is another trajectory, which is implicit, unintentional, and definitely more subtle. The implicit trajectory reflects the informal and sometimes overlooked informal learning that happens throughout experience, observation, and also social interactions in the workplace. So in this slide, I wanted to show you an example of what, for example, a route brings of what the hidden curriculum includes. Things such as when to ask for help. Very hard to learn in a classroom, I guess. And I guess you will agree with this. Being able to prioritize tasks, be able to self-evaluate yourself. I think it's a very interesting topic to reflect on. And then the question that you may ask yourself as an educator, but also as healthcare worker, not necessarily involved directly in a role in education, is how can we make this implicit hidden curriculum that is as part of the implicit learning more explicit? And I've listed here 3 recommendations. One is creating and facilitating experiential opportunities to learn, also called participatory practices. Offering opportunities to the learners to reflect in action and on action, as supported by Sean. And role modeling, which is something that also Rose touched on. What do I mean with participatory practices? Simply put, they refer to any kind of activities, really, tasks, interaction that happens in the workplace and that the workplace can offer to workers. And also, it's very important how individuals choose to engage with them. These practices are essential for learning at work because they can provide the opportunity, in fact, to reflect on actions, and they refine skills throughout involvement, active participation, and they, they don't necessarily always need to be formal or very structured. In fact, they can often be found in our day-to-day routines. For example, we all know that if we are engaging in routine work tasks, we will probably learn to do that task even better. But what is interesting is that engaging in routine tasks is freeing up some mental space for us to learn new things. So even the most familiar activity then can lead to new insights and learning. So I think as facilitators, our role is twofold. We must create opportunities for new participatory practices to emerge. But equally important, we act as role models by engaging in existing practices in the workplace, because they do exist in every work context, inevitably. And we can show our colleagues how learning can be integrated into the everyday work. Here I put some pictures of examples of participatory practices that we organize with the team that I am part of in the emergency department. We have study days, we motivate the individual learning practices, as well as we also organize some simulations. And I think there are three main things that I will recommend to integrate when you want to highlight or create new participatory practices in your workplace. One is to provide close guidance. And as in fact, it would be difficult to learn without the assistance of a more knowledgeable partner. Rogoff, for example, states that like the guidance is what structures the learner's opportunity to engage in participatory practices. Second, I think you need to concentrate on fostering engagement, because naturally we all know that if someone is not interested to learn, it's not that they won't learn from participatory practices, but they will learn less compared to others. And finally, inclusion. Because if it's true that most workplace learning happens in work rather than out of work, the participation needs to be extended equitably, involving especially those people who belongs to protected categories of workers, who are the most likely, or anyways, the ones more at risk of being marginalized in the participatory practices. So one of the ways that us as practice educators apply control and guidance over the learning experience is following a curriculum. This is as well being developed by the RCN, the Royal College of Nursing, and is what I was telling you earlier, the nurses need to complete and achieve in order to then progress throughout their nursing careers in the emergency department. And yes, this work curriculum is definitely intended to expand the theoretical knowledge of the nursing staff, but also create the working opportunities to learn unintentionally at work. Finally, I would like to conclude with this slide just by saying that, I hope I made you reflect a little bit about unintentional learning and informal learning. So even if you don't have a practice educator or facilitator in your organization, don't underestimate the value of informal learning. Don't give up on your own or others' work education. If your organization lacks things such as a shiny education center or a beautiful classroom, but reflect on the fact that if you're a manager, for example, in your team, you might consider that your formal role might be equally, if not less relevant than your informal role as educator. And you want to try to keep your employer informed and aware of all the educational needs of your team. Well, as colleagues, even if you're not involved at a managerial level in your organization, we should think about the fact that we're all responsible for others' informal learning, and we are mentoring them often without even realizing. So I'd like to finish just by saying that it's difficult to capture the moment by moment of the learning, as Billet says, but as educator, I think that witnessing this journey of education, especially if you witness it in your colleagues, is very rewarding. So I'll leave here a list of references if you wanted to expand your knowledge on this topic. And thank you very much for giving me the opportunity to talk to you tonight.
Thank you very much, Sara. That was brilliant insight into your role and sort of the underlying sort of elements of sort of theory behind all of it as well. So yeah, really refreshing. I've got a question, but I think what I'll do first is I'll hold that question and see if anyone else on the floor on the call would like to ask away. So unmute and ask away if you have a question. Give a bit of time for people to think, and I can go with my one first then. So, Sara, thanks again. I suppose my question is that, yeah, is around that sort of aspects of lifelong learning. We are sort of in healthcare, sort of accepting that that is something that we want to do because that's the career we've chosen. And talking around sort of the participatory practice, you mentioned like fostering engagement, and I just wondered what you could explain a bit more about how you fostered an environment and a culture for people to sort of engage in that practice, and if you've got any top tips to share with people around that, if that's okay.
Thank you for your question, Chris. Well, I would be lying to you if I wasn't saying that adults learn if they have an interest in learning. And when I say interest, I mean like something that comes back to them as a profit. That could be a benefit in terms of increased income, better position at work, development in terms of having a higher grade at work. And I don't necessarily, like have disagree with this because I feel like it's natural and it's obvious that someone would like to progress thanks to the fact that they have learned and used their skills at work. And that's what I think is beautiful about having here in the UK a nursing pathway, especially in ED, that is allowing us to progress towards different directions that are, in my opinion, rewarding our desire to learn more. And I know this is applying to other professions as well, not just the nursing one. So in a way, I think, unfortunately, my advice is maybe less, I don't know, my advice is quite practical. You want to reward your staff by giving them the opportunities to develop either in their positions or with a better income. And of course, you can make like you're teaching more interesting, more engaging, more fun for your workers. But the way adults decide to engage with that training is entirely up to them. It's exactly as children's at school, right? Like you can decide to pay attention to the teacher or not, but it's entirely up to the student. The class may be more fun and more engaging. That's definitely going to influence how the people will interact with the teacher and learn from their teaching. But ultimately, I believe we have our own responsibilities over our own education. It's interesting, though, that often we don't realize how much our decisions about our own education can influence our colleagues' education, because we are inevitably part of a society at work. And therefore, people tend to imitate what we do.
Great, thanks very much, Sara. I'll open up the floor. Anyone else have any questions for Sara or Rose? We've got a few minutes left on the grand round to answer any questions you have. So please speak up or put some questions on the chat.
Chris?
Yes, Rose?
Hello.
Yeah, I saw a question. Someone asked, Dennis asked, how can one become a simulation facilitator? So for us at Nanyuki, we got the chance to be trained by the Bristol team. In Kenya, at least I know of 2 facilities where they offer the simulation instructor courses. That is the Aga Khan University and the Kijabe Hospital. So maybe you can look around that. Yeah.
Lovely. Thank you, Rose, for answering that question for us. And just, yeah, last opportunity. Everyone has any questions, statements, comments? If not, we'll wrap up things for this session. I think the silence is telling me that we're at the time that we should finish up. So thank you very much to both our speakers tonight. So thank you very much to Rose and Sara for taking the time to share their experiences and the work they're doing. It's yeah, it's great, all the stuff that you've been doing for a number of years, but and I'm so glad to have you both sharing it at the same time to reflect on practices both here in the UK and in Kenya. Thanks very much for all your questions as ever. If you haven't done already, you can just put your name and details in the group. That'd be great. And then I'm just going to post a link for some feedback. And if you fill out the feedback, you'll get a certificate to say that you've joined us tonight. And the next date for the next grand round is Wednesday, the 12th of March. It'll be 5 o'clock again, UK time, 8 o'clock in Kenya. There's also a link to the WhatsApp group. So for those of you who have joined on the call tonight, not via the WhatsApp group, there's the link. Click on that and you should be able to join the group, and that will keep you up to date with general information about the grand round and some education resources, but also upcoming grand rounds going on in the future. And if you haven't done already and you want to, send us your details and we can adjust that if you're having any difficulties. So yeah, that's me. I'm going to stop talking now unless anyone else has any other comments or suggestions, and feel free to say something now.
Thank you, Chris, and thanks to everyone who joined us today. And I just wanted to end up saying, if anyone would like to see some pictures of the amazing work that Rose and Titus and all the Nanyuki team and all the facilitators are doing in Nanyuki, please follow us on the social media pages of Dharura, either on Instagram, Facebook, X, LinkedIn, all of that, and of course, YouTube.
Great. And the YouTube link should be in the chat as well. So feel free to have a look at that at the previous grand rounds. Well, thanks again to our speakers. Thanks for everyone for joining us, and we'll see you next month.